Welcome to Reducing the Risk, How to Stop Overdose Deaths. My name is Merlene Tucker, and I'll be running today's web forum along with my colleague, Jeff Bornstein. This web forum is sponsored by the National Overdose Prevention Network and produced by Dialogue for Health, both programs of PHI Center for Health, Leadership, and Impact. The support for this webinar series was made possible through funding from the California Healthcare Foundation. Now let's meet the moderator of today's event, Dr. Carmen Rita Nevarez. Carmen is a senior advisor at PHI Center for Health, Leadership, and Impact, founder of Dialogue for Health, and senior vice president emeritus of External Relations and Preventive Medicine at the Public Health Institute. Welcome, Carmen.
Well, good afternoon, everyone. Thank you so much for joining us. We really appreciate having you here and hope you will just jump in with both feet and get involved in our conversation. Addiction begins in isolation and ends in reconnection. We have finally seen a decline in overdose deaths due in part to the very hard work that you are doing, as well as the very hard work that each person in recovery has to do in order to save their own lives. But this is no time to stop now. What does the data tell us? What are the most successful strategies and why do they work? Thank you for joining us in this conversation today to examine the strategies that bridge the chasm of isolation and help people reconnect with those whose lives have been deeply damaged by substance use disorder. Building trust and developing connection is a hard-won struggle, and there have been many decades of experience to inform this work going forward. We'll be exploring that work today. Thank you for being here. Let me talk a little bit about our sponsor, the Center for Health Leadership and Impact. So the Center for Health Leadership and Impact is our sponsor today. We are a public health do tank that helps individuals and teams to transform their vision into data-driven strategies by cultivating leadership, catalyzing learning networks, and strengthening cross-center partnerships. And by doing this, we help to create equitable, lasting impact in communities. Since 1991, almost 8,000 leaders in 53 states and territories have applied our tools and processes to address a wide variety of issues, including overdose prevention. Next slide. We support teams to develop strategies that lead to impact, best practices they can share with others, foster strong partnerships that deepen the work, and develop policy options that implement policy leading to their desired outcomes. And by doing this, it builds the work in a way that is much more sustainable. We'd very much like you to join the overdose prevention movement with us. Just sign up for the NOPN monthly news digest at nopn.org. We welcome your commentary, we welcome your thoughts, and we hope you will gain from this participation. So today's agenda will include a few poll questions with our conversation. It's a conversation today and not as much of a presentation, which is why your participation is so important. We're going to be talking about reducing the risk, how to stop overdose deaths. And we will close out right around 2 o'clock on Pacific time. Next slide. Our learning objectives are that as participants, you'll be able to describe several of the most successful overdose prevention strategies. You'll be able to identify multiple ways to build trust and deepen connection for overdose prevention. You'll be able to explore practical strategies to reduce stigma, increase awareness, and support more compassionate, informed, and accessible pathways to treatment and recovery. I am just so delighted to say that we finally have our conversation with Dr. Ricky Bluthenthal. This is just really something I've been looking forward to for a long time. He is a distinguished professor of population and public health sciences, formerly known as preventive medicine, in the Keck School of Medicine at the University of Southern California, and he is also their chair. He holds the Flora L. Thornton Chair in Preventive Medicine. His major research contributions have been in the areas of HIV epidemiology and prevention for drug injectors and men who have sex with men, racial and ethnic differences in alcohol consumption, consequences, and treatment outcomes, and community approaches to health promotion. Dr. Bluthenthal has published over 210 studies in peer-reviewed scientific journals, such as the American Journal of Public Health, Addiction, JAMA Open Network, Social Science and Medicine, and The Lancet Public Health. He is on the editorial boards of Drug and Alcohol Dependence and the International Journal on Drug Policy. He received his doctoral degree in sociology from the University of California, Berkeley in 1998. Welcome, Ricky, and thank you so much for joining us.
My pleasure, and thank you for your generous introduction.
This is truly an interesting time. I think we'll have a great conversation today. We're all very excited about the data recently released by the CDC that shows that the largest annual decline ever recorded happened in 2004. And just to give a few of those numbers to the audience that didn't hear about it, there's a total decline in the drug overdose death rate of 26.2% between 23 and 24. There were over 100,000 deaths in previous years due to overdose, but little less than 80,000 in 2024. That's some real movement forward. The deaths were primarily illicitly manufactured. Fentanyl had decreased by 35.6%. So all of you working in fentanyl prevention, you're making a real dent in the numbers. The decline spanned all age groups, genders, and racial ethnic groups, with the most significant decreases occurring among younger age groups and Black non-Hispanic individuals. So, starting with that bit of good news, finally, I'm going to just pose the first question over to you, Ricky. What risk do you think we face if communities interpret this decline as a sign that the crisis is over?
Well, I mean, as David Purchase, the godfather of syringe service programs in the United States, used to say, prevention is never over. And, the truth is 70,000 deaths is almost double the height of the death toll during the AIDS epidemic. So it's still a significant crisis. And, the truth is that many of these overdose deaths are preventable. So, let's make the goal to get to zero.
Thank you. That's a good foot to start on. So let's dive in a little bit. How do we help individuals and families and communities rebuild trust and deepen connection with people struggling with addiction? What do we know about that? What's been your experience?
Well, I come out of it probably from two key experiences. So, on one hand, I had parents who were both alcoholics, so I sort of know what it's like on the inside. And then I spent 35 years doing work in the space related to harm reduction. And I think what I would distill from those combined experiences, are a few key points. Unfortunately, in our culture, I mean, there's a sense that, the way you help someone is by not helping them, right? That whole idea of enabling. I think the lesson of harm reduction is that, that could work for some people, but for most of us, if we're having a problem, what we need are resources. And, those doesn't include just, things or money. It does include connection and understanding and engagement, and someone to work positively with us around, why are we doing the things we're doing, and are there alternatives that might be safer? So, I do think, in my experience, few problems solve themselves without intervention. And one of the most important things that we can do is really engage with people. The other piece is, and I think harm reduction is a great example of this, is that we do have to think outside of the box. One of the things that's really, I think, key to why harm reduction works is it sort of says, you know, if you have a problem, it may be because you're missing a resource you need, right, to prevent that problem. So we know with syringe service programs, they give people syringes, and so that's really effective at preventing HIV spread. We know through giving naloxone out to people that that's really good at increasing response times and having more reversals. So, giving people something that's useful to them is a great way to start the conversation, and help them find their way towards better well-being. I think the last thing is, not the last thing, but another thing is, folks need to have agency in their lives. And a lot of times people will respond to the absence of agency with substance use, like they feel out of control. And so using substances are one way for them to feel in control, whether it be of their emotions or how they interact with people around them. And so I think always attending to the idea that folks need choice. And one of the things that's really unfortunate, really about our healthcare system and, a lot of our approaches to substance use disorder is that we feel like, oh, you're so desperate, you should take whatever I have to give you, right? And that's just not how humans work. People need choices. They need to be involved in the conversations that have to do with their lives. And, we should be working, and that's that connection to empower people to make the best choices they can for them and recognize that it might be different than what I would do. But you know what? I'm a parent. Like I have adult children. My kids are amazing. They are my dream come true. They still do things I don't like. And you know what I do when they do that? I keep my mouth shut because 95% of the time they're doing what I want. And I do think that we do need to approach folks who are struggling with love, compassion, and witness, and recognize that just because something worked for me doesn't mean it has to work for them. It has to work for them as well. And that's really, it's funny because I started with the whole idea of this idea of enabling, right? And oh, we don't want to enable people, but the truth is that works for some people. So I have no gripe with that. If that's your jam, use it to get to the place that you want to be. But we shouldn't let that drive everything in our approach to people with substance use.
Yeah, let's talk a little bit about agency and how important uh, developing a sense of agency is in this field. Can you give us a couple of examples from the work that you've done over time about how programs can help people to really develop a sense of agency?
Sure. I mean, I think one of let me just step back a little bit. So a lot of the research that my group and I have been up to the last 7 or 8 years focuses on this idea that'll sound snooty, but I'll break it down, called ontological security. And it's just this basic idea that for people to sort of create the circumstances where they can be healthy and well, they need a few things, right? They need social constancy and material security. They need, um, um, access to like routines that are healthy. They need privacy, right? And, at the end of at the place where I started this work, which is with folks who are really low income and often unhoused, those folks don't have a lot of agency. They have a lot of desperation, and their daily activities reflect those desperations. But if we want to help them get to a better place, when you give them choices, you find that people make better choices, right? And so, I think one example of that is, syringe service programs, give out syringes, but they do a bunch of other stuff too, right? And even the syringes they give out, they don't give out one size, right? The typical needle exchange program is going to give you 12 different choices, right? And then you choose what works for you. And then they're going to give you other supplies for whether you smoke or whether you need a cooker or cotton. They're going to give you different kinds of condoms for protection, from HIV and STIs. Like choice is a really, it's sort of embedded in everything that happens in these locations. Similarly with treatment, we want to have more choices, right? So, right now you sort of have really heavily regulated methadone available to people and buprenorphine. And, one of the things we've learned is some people prefer buprenorphine to methadone. And then some people want a long-acting injectable. And I think each time we add more choice, we actually reach more of the population that needs those services. So in some ways, giving people choice is one way to activate their own agency and meet them where they're at, and innovate. And I think you end up helping a lot more people and protecting the public health much better than we do when we just sort of say there's a narrow lane. So let me just make one other point. My entire adult life, we've been in the midst of a war on drugs. And so the primary response societally to people who have substance use disorder has been incarceration, which is the opposite of choice. When you put someone in a jail, you're taking them away from everyone who loves them. You're reducing their access to education and employment. You're jeopardizing their housing status. You're disrupting romantic relationships they might have, friendship networks they might have, all the things that for those of us who haven't been incarcerated are huge part of our happiness and success in life. So you're taking away the very capacity of someone to act. And then, of course, those deficits continue throughout their life, both through stigma and then just real world. Like, we've rolled back a lot of these laws, but when I was growing up, if you got arrested for a felony drug charge, you couldn't get financial aid for higher education. So, we know when you take away choice, people do worse. And I think what the experience of harm reduction has been the last 30 years is when you give people choice, you get better outcomes.
So help me if I'm wrong here, but am I hearing from you that choice helps people learn better, learn how to manage their lives better? Is that your experience? Is that what you're getting to?
Yeah, for sure. For sure. I mean, everyone look, I'm a sociologist, which probably means nothing to anyone else, but one of the things sociologists are really interested in is opportunity structures. Opportunity structures are built on choice, right? So if you can give people more opportunities to do the things you would like, and sometimes even incentivize those things, you'll get the outcomes you'd like. If you punish them, you usually don't. And I just there's just a whole body of research on this topic. And because of our political economy, our political culture, we don't like incentivizing low income people. But guess what? I'm not low income. I get all kinds of incentives to behave, right? And I get ample rewards for that behavior. And so, I do think that it works. We should apply it to everyone.
Yeah. Well, I want to get back to incarceration in a bit and what we see as a result of incarceration, because I think that's something to really get back to and underscore and better understand. But given what you've just said about harm reduction and being sensitive to the fact we know that there are lots of people who are on this webinar today who cannot even use that term for lots of reasons. And I'm sure they'll start to pile on in the Q&A talking about what their circumstances in their particular community. But given that that's the case, what kind of messaging do we need to use in order to build public understanding and trust into these strategies? We'll get into strategies in a bit, but let's talk a little bit about what kind of messaging is the kind of messaging that invites people to understand rather than makes them throw up a wall of rejection and abhorrence or whatever their reaction is.
Yeah, I mean, I do. I mean, I guess there are a couple of things I do, right? So one is, we've conducted not just me, many people, a wide range of studies using different designs and observation periods to demonstrate, the basic premise that if we're more generous with people and giving them the things that they need, they are going to significantly change their behaviors in ways that we want. So one of it is effectiveness. Like we can, and I can, I've said this before in other public forums, to say it here. Like, if you do what I want, you will have more people alive and you will increasingly have people with fewer problems. I really, I think I can empirically demonstrate that. So I think that's one important thing to say. I think the other thing that's important to say is that, there are no silver bullets for any significant problem we have in the world. Right. So, like, a lot of times you find yourself in conversations with people of like, what does this message say to kids about drugs? Or what is it, what about we're rewarding people for misbehaving, right? Those kinds of thinking. And the truth is we all live in a world with many messages and lots of different reward and punishment structures. The truth is, when we're talking about people who develop chronic substance use disorder, many of those folks, they're not there because there happened to have been a needle exchange down the street. And how do I know that? Because for 30 years, I've been conducting studies with this group. And, folks have adverse childhood events. They have physical and emotional trauma. They have poverty that they're dealing with. They have multiple bouts of incarceration. Like, there's been a lot that's happened to them that is really negative before they get to that point. And so, if you want a message about how to keep your kids from using illicit substances, I do have advice for that. Witness them, engage with them, love them up, give them opportunities to do other things. They may still end up using substances, but the truth is every year they're older before they start, you've reduced the potential harm. And the fact that they have robust alternatives to of satisfaction and meaning in life kind of works. And I think it's an important, it's interesting because, I'm 61 now. So I've seen a couple of different parenting styles over the years, right? And I was a latchkey kid growing up, so that's what the 70s looked like for some of us in the late 60s, and then you've got you get different kinds of models. But I do think that the truth is, you know, if you want to prevent illicit substance use in your family, you pay attention to them. I mean, it's connect to them, give them alternatives. If you see they have an itch that's not getting scratched, be creative about how to satisfy that itch. But it is that engagement. And then, of course, the other piece is, some people have mental health disorders or conditions that go untreated, which is very common in our society, and try and get people the mental health therapy or medications they might need to help them address those issues. And we don't do a good job of that as a society either, right? I mean, I've worked in medical schools most of my adult life. And, at this point, I think it's safe to say that whatever model of healthcare we have now, it's mostly a scarcity model, right? So the incentives aren't to provide patients with care, it's for someone to make money. And that gets in the way, and we probably need to reverse that if we want to, have as healthy a society as we can. I'm sorry, I'm going all over the map every time you ask a question. Sorry about that.
No, I think that's really good. I mean, we have a lot of, if this were a straight path, we would have solved it by now, right? Yeah. A lot of good comments from the audience. I just want to bring one up here because I thought that this was, let's see. Okay, so somebody here commented on, and I want to sort of underscore it. Profound statement. Love them up and pay attention. Thank you for that. I think it was really, really nice, really lovely how you said that. And then we have somebody from a tribal community saying, this is said from a small rural area with serving a person that continues not to change in their behaviors. We've loved them up so much, they come to get more and more gas cards, phones, etc., get out of trouble, and then returning to the same misdemeanor crimes. So, just some comments about the reality of that. People that are suffering in recidivism. Can you talk about that a little bit?
Yeah, I mean, I can. And, obviously, as you said earlier, if we had answers to all these questions, we'd probably have solved them. I think my statements are always dollars to donuts, right? So when you think about someone who you're trying to help and they keep not doing what you would hope they would do, there's one thought to think of first, which is that the resources you're giving them are probably preventing something worse from happening in a real way. So I would recontextualize the resource giving as, sure, I don't like it that they took a gas card from me and they're probably going to keep using meth. But the truth is, the fact that they got that gas card from me means that something else isn't happening. So they're not selling their body. They're not breaking into someone's house. They're not doing something reckless. And so that's better than doing nothing, and certainly better than putting them in jail. So that's one thought. I think the other is to use the connection that they keep coming back to begin to redirect the conversation and get at what are the other things that are going on. So what are the other needs that they have that aren't getting responded to, which is why they keep doing the same behavior that they're in. So I would take that engagement as an opportunity to learn more, ask questions, figure out, is it, hey, I got to get my kid to childcare and I don't have a job, and this gas card is allowing me to make sure that my 4-year-old is getting some kind of introduction to education. Like, learn more. We don't know what's going on in other people's lives. And I think I would use the fact that they keep coming back, not as oh, they're scamming me, and more as an invitation to learn more and engage more deeply with them around their circumstances, then try to figure out, what is the other redirect that might help move towards something that's probably better for them in the long run.
Yeah, let me ask this. Let me ask a question posed by the audience. Do you think you'd have different opinion if you yourself had actually experienced addiction?
Every experience I have changes my mind. So I'm sure I would feel differently. I would like to think that what I'm sharing with you, comes out of my experience of addiction with people I love. And I've had, aside from my parents, there have been many people that I love who have been addicted to substances. So it is informed by that. But yeah, I mean, I can't, I think these problems all look different depending on how you enter them. What I'm trying to do as a scientist is, distill the things that we know scientifically, right? And then add a sort of patina of my old guy, 61-year-old wisdom on top of that. And I with all humility, I recognize how painful it is when you have someone really close to you engage in behaviors, that are destructive and problematic and could be harmful to you. Like that is so difficult. And so what I'm really trying to do is imagine a world where there's resources for you too.
Mm-hmm.
Right. I mean, I think one of the things that we perhaps don't appreciate enough is that when we create scarcity for mental health services for people, that comes back on us, right? That hurts us because people who need care aren't getting it. And so that's really where I'm trying to lead us to the extent that I can. Is there are no easy answers, but there are some principles we can follow. Most of them have to do with recognizing agency, giving people resources they need, approaching them with compassion and attempting to understand them, and then working the problem. And a lot of times when folks are struggling, they what they feel is that isolation and there's no one helping me. And we do that, our political economy generates isolation,
Yeah.
right? Even if you're not poor, it generates isolation.
Yeah.
Right. And so we need to cut against that and come up with some different approaches that, that engage us, engage each other.
Got a really good question from the audience. how do you measure or predict choice? How do you measure choice? Opportunity or entitlement? How do we what kinds of strategies do you know what kind of tool do you use to measure choice?
Yeah, I mean, one of the things I mean, I have thought about this, maybe not as deeply as some of the other things, but so here's my argument about it, right? Is you go into your typical supermarket in the United States and you're overwhelmed with choice, right? Like, you go to the cereal aisle, there's 75 feet of different products in that category. There are probably 200 different things that you can choose from like toxic, sugary, hurt your mouth to eat, like Captain Crunch. Sorry, guys. To granola, which is what I eat now, right? You get the whole range, and you don't know what people need. And so I think it's less of my approach to it is thinking less about how do I measure what's a good choice versus a bad choice, or what kind of choices should be available to people, but more the principle of we should give people more choices, whatever it is. And if we treated substance use disorders like they were people's preferences in cereals, you would have lots of choices for kinds of treatment and modalities and medications and no medications or different kinds of medications. And I think when we invite physicians and patients to have a dialogue around what they think might work, you usually end up with pretty successful protocols that can help people have a better life and reduce some of their health risks. So, and I do think because we've characterized substance use, whether we want to or not, culturally as like a moral problem, people don't want to approach it that way. Right. But if we just concede, like the Christian Bible does, that we're all sinners, maybe we can figure out, to get back to, these sort of ideas about people need things, they're not getting it. Let's just sort of give them what they need, um, and use that as our sort of North Star, rather than take things away from them, restrict their choice, prioritize the needs of people who aren't even really affected by it, which happens a ton.
Yeah, yeah. Um, so just a nice comment here that'll help us segue into something I did want to get into, which is the incarceration issue. Because, like you say, it is the absence of choice. And here's somebody saying that the inmates they work with are overwhelmingly admit that they turn to substance abuse out of a pain of loneliness, that they overwhelmingly admit addiction. We try to connect them with organizations upon their release to help them remain drug-free, improve their life, and to prevent recidivism. So let's talk a little bit about about incarceration as a strategy, because there are, really the recommendations are out there, from throw them in jail, throw away the key, put them in jail to get them into treatment, put them in jail to save their lives. What are your thoughts on that? What have you been learning about incarceration in the spectrum of ways that people respond to substance use?
Yeah, I mean, let me just start. I mean, I'm sure there's some people out there who've benefited from incarceration. I'm just not sure I've ever met anyone, but I'm willing to concede that it exists. So I, but so, but I don't think it happens very often, right? And I don't think it happens very often for the reason I just shared, right? You're taking things away from people. You're putting them with a group of other people who are very angry and frustrated and have a lot of needs that aren't being addressed. You're desocializing them, right? So, when people come out, they're not used to the way the rest of us who've not been incarcerated live. That can create its own problem. You're destroying their educational opportunities for the most part. A couple of years, probably 10 years ago. So my office, I'm at the University of Southern California, but I'm at the Health Sciences campus, which is in East Los Angeles. And We did interviews with people that were recruited from the neighborhood, so East Los Angeles. So, older people who inject drugs, who are Latino. And, when you talk to those guys, you realize, most of your formative years were spent in jail. Many of those men made it to adulthood literally not being able to read or write because they had spent from the ages of 11 to 22 in jail. They had real difficulty forming, successful relationships, romantic relationships. They had real difficulty holding on to jobs. They had the stigma of their incarceration, right? They didn't learn any skills. I mean, so when you're thinking about what do we want for the people who we feel like we might want to incarcerate, I don't think it's that. I don't think it's 10 years later we want an adult man who's angry, isolated, perhaps can't read or write, and has no economic or social prospects. So, what I like to think of is what could we do when we see the problem happening, right? So I did an interview with this person in Riverside. The podcast is called Falling to Freedom, you know, and he's an interesting case. He got sideways of his family and the law at an early age and was put in jail. And then miraculously, 30 years later, like figured it out. And he owns a home and he's a pastor and he's got a business. So, he's not using drugs anymore. He's doing great, right? But gee, it would have been great when he was 12 and he stole a car for someone to have said to him, you know what? I'm not going to put you in juvenile. I'm gonna lean into the fact that you like to drive. So let's come up with an incentive plan so you can go karting. Like it sounds kind of trivial, but it's like that would have been better and less expensive. I don't know how successful it would have been, but you do that a couple of times and maybe you find the trigger that locks him in to the person he became. Because that person was there when he was 12. No one saw it. Like it was there, but no one said, you're sideways. Let's have a serious talk. Let's figure out how to get you back on track. And we need way more of that and way less of our retail incarceration, which is basically what we've done. We spent most of my adult life putting people in jail for relatively trivial offenses that end up destroying their lives and acting like we're doing them a favor.
Well, you just told the story of one of my cousins who at age 11 ended up in juvenile detention for a very trivial offense. And then went on and went on and went on and got involved in all kinds of stuff. And now is dead as a result of an overdose. Good little kid.
Yeah.
Tough little life.
Yeah.
Maximum security prison. Just terrible, 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 sad, wasted life.
Yeah.
You see it over and over again in this, in this field, and it's hard, I think, to maintain your compassion and hard to keep your understanding alive and your hope up. And we'll talk about that again in a bit, but I want to get a couple of other comments that folks from the audience have come up with. How do we get folks to give up on hopelessness, become more caring about themselves and those around them, develop empathy for the situation, and have strength to get out of adversity? So how can we get there from here?
Well, a lot. It's interesting. So I'm pretty aware of the way my own thinking has changed over the course of my career in life, and I'm always, when I have a new insight, shocked at how long it took me to get there. But eventually I get there. And I think for people who are in the midst of chaotic substance use and homelessness and, underemployment and, food insecurity and untreated mental health, I think it's on us. I really do think it's on us. Like, the people I've talked to that, in the course of my studies and the things they have gone through are not things that people can resilience their way out of. They really need us to extend them a helping hand. And for a while now, I've been advocating, like, we have the resources. It's easier for me to change than it is for someone who's, doesn't know where their next meal is going to come from. So I really do, and that's why I advocate generosity, you know, because it's hard. I mean, we're about to do a study now where we're looking at how people spend their days just to reinforce the idea that, like, the things you think about them are not true. Like, they don't have a lot of free time, right? And they're not particularly mobile because the world is full of, threats and danger when you're at that point where you're unhoused and you have the substance use disorder. So, the rest of us, I think, need to change to help them. And we have our recent papers have really been arguing against encampment sweeps as an example. Like, that's the new incarceration, right? So we sweep these encampments. So what happens? People lose ID. They lose food, clothing,
We just
sometimes
lost
pets.
your sound.
Oops. Can you hear me now?
Yes, we can. Thank
All
you.
right. I don't know what I did there. It's interesting. Anyway, so they lose a bunch of things they need to operate in the society. ID. Sometimes people lose the ashes of their beloved parents. They photos that are irreplaceable get thrown away. I mean, these are all devastating. I mean, it's like, as a house person, right? If someone burned my house down tomorrow, like, that would be devastating for me. And everyone around me would recognize that, man, Ricky, that really is awful. We do that to unhoused people without thinking once a week and act like we're doing a social good. So yeah, I think the independent variable is us. It's not them. And we need to approach the circumstances that they find themselves in with patience, compassion, humility, flexibility, and imagination. Because it's difficult to dig out of that hole, particularly when we keep hitting you over the head with additional assaults.
So, a comment from one of our audience folks. As a daughter of a parent with alcohol use disorder, I'm glad you started with mentioning that lived experience. One thing I struggle with is that while I understand harm reduction approaches for overdose prevention, how do we still prevent adverse experience to close family members, especially children, while not adding to stigma and shame?
I mean, I'm going to sound like a broken record. I mean, I think that's a great question, but I think the answer is we need to give them more resources. We need to try and make it easier for them to get alcohol treatment. Um, we have new medications that deal with various substances. I mean, usually people aren't using just one thing. There's usually a couple of things going on. So, we need to get good at using those in different ways to lift families, who are suffering through this up and give them some additional protections. I mean, I will say, and I'm not going to say this in defense of my parents because what I'm going to say is my truth about it. They loved me to death, 100%. I am the man I am because of that. So you can have a substance use disorder and meaningfully, positively impact people that you care about at the same time. So we need to be open to that possibility as well. And I think these things are complicated. I mean, the questions I always dread, are the specific ones about my cousin, right? Because, you'll have that person in your family system, that really harms everyone else. They'll make a bad choice. They'll steal someone's car, get in a car accident. Now someone else can't work. They'll spend a bunch of money that we don't have, and now we're all unhoused. I mean, those things happen. Um, and um, and the substance use contributes to it. And I think some of the answer is the rest of the us who don't have those problems should be leaning into those circumstances and figuring out ways to help that family in general. Um, things like universal basic income, high quality public education, free public transportation. Like there are all these things that we make people pay for. And like if I had to pay for them as a, distinguished professor and chair of a department in medical school, like I don't even think about that. That's not a problem for me, right? But we make the people without my resources pay those things, and it's a cost to them. It's a real cost to them, and act like it isn't. So yeah, I just think we need more generosity. And recognizing that if we work with people, in social work, what they typically approach is a strength-based approach. So you have a parent with a substance use disorder, make it ridiculously easy for them to get medication for their treatment. We don't do that right now, but really make it easy to get treatment. Um, if they're unhoused or their family's unhoused, house the whole family. I had the good fortune, this was a long time ago now, probably 17 years ago, working with this group called Shields for Family in Los Angeles. And they were one of the few treatment providers that could provide housing for a mother and more than one child, right? Like, think about that. Like, okay, you can go to treatment, but you only get to bring one kid. I mean, that's bananas. I mean, and we have things like that all over the system. I have a colleague, Kelly Knight, who wrote a terrific book called Addicted Pregnant Poor, on women with, serious substance use disorder who are having kids. And one of the women she describes was able to get on methadone when she was pregnant. But literally the next day after she'd given birth, they took her off of methadone. That was the policy. Like, who does that? Like, you know what I mean? When you're like, why would you do that? That doesn't make any health sense for the baby or the mother. So, our whole system is riddled with these like wackadoodle approaches to helping people that are mostly based on this idea that your desperation should mean you should take whatever I give you, and that you don't deserve to get what you actually need. And I prefer in a world where people got the things they need.
Yeah, that's a very sage but sad observation. Um, I want to go back to the other question that I brought up and try to get us to focus a little bit on how do we or what has your research shown so far with respect to how we can help avoid the impact of the stigma on the children, because a number of questions are coming up from the audience about children and families and their resources, and we're talking a lot about the person with the substance use disorder as their personal issue. And I wonder, what have you learned so far about some of the better strategies around the children?
Well, here's where I get to be my best version of scientist. I have not done those studies. I have no idea. I'm sorry to say that is outside of my area of expertise.
I'm glad you drew the line there, because that means that probably we're going to just have to get to that with another person.
Yes, please do.
But it is, it's an important question, because substance use disorder obviously doesn't occur in a vacuum. And so I think we need to figure out how we can have a good conversation about what some of those strategies might be.
Yeah, I mean, I do have a higher level thought about just stigma as an intervention, which is that I don't think it's a very good intervention. Um, uh, it's probably not as bad as incarceration. But again, if you're sort of thinking, how do I get people to do things? What's a more sure way of getting people to do behaviors that are probably in their best interest and the best interest of society. It's seldom is stigma the way to get there.
Yeah, yeah. Well, let me just reflect for a moment back on the CDC study and see what they said with respect to their review of the evidence. Um, so again, CDC, and this is a federal study, said that expanding naloxone access increased distribution and availability of naloxone to reverse opioid overdoses, and that was very effective. One of the effective strategies that was helping to prevent that or helping to promote that decrease in overdose death rates. That treatment access, as you mentioned, greater access to evidence-based addiction treatments such as methadose and buprenorphine. Again, the CDC is saying harm reduction efforts with the expansion of harm reduction services, including syringe service programs and fentanyl test strips. And that there are some changes in the shift of the drug supply, that potential changes in the illicit drug market, including a decrease in the potency of fentanyl. So these were some of the things that they lifted up. And I wondered if there are any of those factors that have contributed to the decline that you'd like to underscore.
Yeah, I mean, the other thing I would add is, I mean, there's probably two or three things. So one is, there's been a pretty significant transition in many places away from injecting opiates to smoking them. So my suspicion is that that reduces the overdose risk somewhat. Um, there is a susceptibility argument, which is that, 1 million people have died, in the last, 10, 15 years. And so some of the people at greatest risk, the numbers of people at greatest risk is declining. And so that could also be contributed to it. I mean, epidemiologically speaking, it's sort of just a sort of a change in the who's available to sort of die from overdoses. So I think that's probably some of it. Um, and I do think that there has been some maybe modest change in the prevention of overdose stigma. So, like, what I mean by that is, like, and I see this with my own adult children, like, you know, they carry naloxone, right? Not all the time, but they know what it is. They know how to identify an overdose, like, and they're not in those worlds, right? So I do think the public awareness in general has had probably a positive impact. Um, and then there's also been some other, really innovative, almost technological solutions. And so I'll do that one and then one more. So, I do want to lift up Stephen Murray's, um, um, oh God, I can't remember the name of it now, but he basically has a telephone line. And people know about it. There was a great NPR story about it. So if someone's about to use drugs, they can call this line. They'll talk to an experienced counselor who will give them advice about, like, here's what you need to do. Give me your address, leave the door unlocked. So and then I'll just be on the phone with you. And if you end up not being able to respond, I'll call 911 on your behalf. I think it's safer site is what it's called. Um, so, those kinds of things, I think can have a real, there's a broader caring infrastructure for people who are vulnerable to overdose risk. So that's one. And then I do think there's probably some benefits of, buprenorphine is much more widely available. And so even though it's probably not as popular as people who don't use opiates like me would like it to be, but I think that also is what I would say eating into the denominator,
Mhm.
right? So the number of folks engaging routinely in behaviors that might lead to an overdose, you know what I mean? That group is shifting, and maybe it's getting smaller, or maybe it's not growing as fast. And I think that's also helpful. Um, and just in terms of the naloxone distribution, I also want to make sure we don't lose sight that naloxone is an inert object that can do nothing by itself. So the real hero of naloxone distribution is the peers and bystanders who take it upon themselves to save a life. And that's the actual independent variable. In fact, getting back to my earlier conversation, this is a great example of what I'm talking about. Is that those of us who don't have this problem, gave that resource to the people who are dealing with it every day, and they acted in a way that saves people's lives all the time. And I think that that's a great model for how to approach a lot of these challenges.
Yeah, yeah. So it's Safe Spot OD Hotline, Stephen.
Thank you. Yes, and I know I love the guy, so I can't believe I just brain farted it. Sorry. Thank you for getting that.
We all go there. So one of the things we wanted to just sort of get to is what is it that makes the effective strategies work? Is it access, trust, consistency, compassion, policy, or something else? Anything else you want to pile in on that?
Yeah. I mean, I think the first couple of things you said, I certainly agree with. I mean, our policies have slowly became aligned and now are becoming unaligned with these approaches. So hopefully we'll swing back to the more effective options. I mean, there are all kinds of things that you can do, and people, I do think, centering the experiences and insights of people who use drugs and asking them is probably the best thing we can do because they come up with stuff all the time. And, I spent a lot of years in school. I've got nice titles and fancy degrees. The first time a person who used drugs suggested that we should be delivering naloxone to people, I was like, I don't know. That seems like, I don't know. For some reason, that makes me feel weird. Right. And of course, that person was Dan Big, who's the godfather of giving naloxone out in this country. And it saved, who knows how many people because he had the good sense to like, hey, this is what we need. Right. So I think engagement with the population at risk is like the first key and probably the last thing we want to do, but it should be the first thing we do. And people, just to let you know, people are innovating all the time. So, the safer spot thing, that's an innovation, right? People in LA, we have homeless health care now that's running around with carts that have oxygen on them, right? So they can administer oxygen to people. There are other folks dealing with the challenge of fentanyl by making available safe cutting materials, right? That'll reduce the potency of the drug to folks. So, and there are probably, I'm sure there are thousands of other things that people do that I don't even know. I don't know about. And I think looking to them for some of the answers. I mean, our best answers have come from them, right? Like I think that's the important thing to remember. When I was running an illegal needle exchange program in Oakland in the 1990s, I didn't come up with that idea. Someone who used drugs came up with the idea. I just listened to them and did what they told me to. Right? It's the same thing with naloxone, the safer supplies. I think we need to engage with the population, empower them, and, they will lead the way.
So, a really good question came here. Black men over the age of 40 experience the highest rates of fatal overdose. Have you worked with this group on harm reduction? And what insights or outcomes did you observe? And how do you help them to understand harm reduction?
Well, I mean, I have had some experience. I mean, I'm that guy now, right? So I'm over 40. Look, I do think there can be challenges because there are lots of things going on in people's lives. So, I'll use an anecdote here, which is I don't want anyone to assume as a generalization. It's not. It's just my experience. So I've been in Los Angeles. Well, I grew up in Los Angeles and then I left for a while and now I'm back. But I've been here since '98. And for years, there were areas in the historic African American settlement in Los Angeles where there wasn't very much harm reduction activity. And so working with some community-based groups we were able to open a site in Watts for the first time, which was great, and nobody came. So, And one of the things that we did is we changed that model to basically being delivery. So folks got to know the people who were using drugs in the neighborhood, and then we would just bring stuff to their house. And, for complex reasons that I could speculate, I will not, but I do not understand. They just weren't willing to come to the site, but they were happy to get the materials. And so that's how we did it. So, I do think one of the things that like racial segregation and mass incarceration and over policing does is it makes you less comfortable in your own community and risk averse around exposing yourself. And so that could have been part of the story of what was going on in South LA. The point is, the way I responded to that is let's just keep asking questions and engaging with them until we can find a thing that works for them. Because that's the point of the activity, is to sort of get them the things that they need. And, in the social service area, people aren't allowed to do that enough. So we know, like, one of the things I was involved with another group, uh, 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 Community Health Project Los Angeles, and they were doing like some amazing case management and legal aid interventions for people through the Law Enforcement Assisted Diversion Program. Um, and they had great outcomes, but they were doing extraordinary things because they had permission to do extraordinary things. And let me give you my favorite story I heard. So there was a transgender woman who was in a residential treatment facility in Hollywood. And for some reason, there was a break-in, something happened. That residential facility had to close for 60 days. So this person was about to be unhoused and untreated. And so our case manager found her another place, and she said, "You know what? I've been there. I don't feel safe there." He's like, "All right, well, you're not going there. I need time. What can we do right now that's going to make you feel a little bit better?" And she said, "Well, I grew up in Huntington Beach. It'd be great to go down there and spend some time at the beach and maybe see my mom." And he's like, "All right, let's do it." And so he took her, they drove down to Huntington Beach. He got her a place to stay. They hung out at the beach for a while, got some food, called the mom. The next day, the woman spent the day with her mom. And all the while in the background, him and his team are trying to find another place for her. And come Monday, he's found one that she finds acceptable. And he comes and picks her up and takes her there, and she's off and running again. That's the kind of intervention I would do for one of my kids if they needed it. And that's the kind of intervention we need to make routine in the society. Because that woman at that moment doesn't have the resources to do that for herself. And no one should expect her to. So I think their solutions are out there. We just have to be willing to really, lean in hard and be creative and imaginative and not get caught up in it's got to be this one thing. And let me just do my other rant since I'm leading that way anyway, which is I can hear people thinking, well, this costs a lot, right? That might have cost a lot, but it's way cheaper than putting someone in jail. Or it's way cheaper than that person having to sell their body the next day to pay for housing. And it's way cheaper than them starting meth use again, right? Like, all of these things of leaning in are less expensive than what we have been doing for decades. And all of these things are way more effective than what we have been doing for decades. We would have a much better society if we approach problems this way.
So, that sort of leads me to think a little bit about formation of helping institutions, and then how you think about developing programs, and then how programs become adopted by by institutions. But yet we're at a time right now where the faith and trust in institutions is really at the bottom.
Yeah.
And so if you are working as a part of an institution, as I suspect most of our listening audience is, what kind of what kind of thoughts and wisdoms can you share with them, because they're working with institutions with institutional rules,
Yeah,
and
yeah, yeah.
those rules are based on budgets, and those budgets are very real. And
Well, I mean,
so let's get into that a little bit.
yeah, yeah, yeah. I mean, I'll just resurface the budget thing real quickly, just because I think it is. Look, we waste so much money on things that don't work, right? But they're politically popular. I mean, I'll just leave it there, right? So the truth is, the budget thing is part of that scarcity thing, but it's scarcity for some people, right? So like when I think about the healthcare thing, hey, do I experience healthcare scarcity? No, I do not, because I'm a chair of a department in a school of medicine. I know all the other chairs, right? So even though I'm not a physician, they are certainly happy to accommodate the needs of me and my family, or even people I know, right? So I think that's one piece. The other is like these rules come and go, right? So right now you can't say harm reduction. When I first started doing research in this area, you couldn't say psychosocial. And for a while there was a whole thing where you couldn't say sex work. Like they come and go. I mean, but the spirit of the work can continue. And so if someone tells you don't write harm reduction down, so don't write it down, but keep doing the work the way you know best and the way that's effective. And the other good news is there are these third elements, right? So what do I mean by that? So you sort of kind of front line of these kinds of interventions are your family, and then like what's the government willing to pay for? But then there's this third group out there, right? And oh, by the way, the third group is the folks that brought you needle exchange and brought you naloxone distribution, and are the mutual aid organizations that have sprouted up, even before COVID, but really during COVID, and then have continued, where people are taking care of each other on their free time, right? And so investing in those other institutions, I think, is very profitable and sensible, even in the face of some of the challenges that are being intentional. The erosion of these institutions is intentional, right? They're not offering you, they can't explain to you how what they're doing will actually make us all healthier, right? Because it doesn't. So just know it for that's what it is. They have a political project that they're engaged in that worked for them politically, right? And hopefully our politics will change, and we'll move away from this sort of cynicism and nihilism, I think, that characterizes what's happening right now. And embrace the fact that we can positively impact each other because we do it every day, right? We see it in our own families and our neighbors and the ways that we all lift each other up. But when we're in difficult economic and physical circumstances, and we've had traumas and maybe ongoing traumas, people need us to lean in. And so don't stop doing the work, work even harder. Um, um, but know that that's part of the solution, right? We literally have needle exchange because people are willing to break the law to make that possible. We have naloxone because drug users said we need this.
There's a nice story here I'm going to share with everybody. My cousin is 3 years sober today. He was unhoused and using for 10 years. It took our whole family bringing him home and providing support with the boundaries of him engaging in some form of treatment that would work for him. It took 2 years for him to be able to start working again. He started working with my brother-in-law a year ago, and now he's operating his own handyman business that's licensed, insured, and bonded. I struggle to figure out how we as organizations and government can provide that. So I think that gets back to to what you're laying out.
But when that happens, that I'm glad we can, but we can institutionalize those processes. But let me just say that your cousin isn't alone, right? I mean, one of the guy, this guy Michael Marquisian, who ran CHPLA for years and worked there for decades. That's his story. He was on the street looking to score. There was a meeting there. Some pretty woman walked into the meeting. Him and his buddy followed her in. They're in the meeting. A guy sees him, says, "Hey, what are you doing after the meeting?" And he goes, I don't know. He's like, "Why don't you come back to my house and let's get some dinner?" And this stranger brought Michael in. Michael moved through 3 or 4 or 5 different living and eating and working arrangements over the next month or two and stopped using. Right. And then was embedded and then got to work. So, what I would say is we want a society where non-governmental and government agencies have the capacity to do that kind of activity, without restraint. It's like, so don't worry about the money, worry about the person, and figure out some useful way. And then accept like everything isn't for everybody. And people aren't ready for everything at the moment you want them to be. So just recognizing that those things are true. Um, um, and then, I mean, maybe the other thing is like making it easier for families to do that. I mean, one of the things I'm sure this person's family went through is that was really also expensive for them as a family, right? So people were reallocating resources that maybe were going to pay for a college education or get a new car or get, whatever it is, pay for a baptism, but, whatever. They're making sacrifices to make that happen. But we're in a rich society. I mean, we could subsidize that in a way that makes it, a little less onerous on the folks who are engaged in helping people.
Well, and I think what I'm hearing here is that, again, there's not one path. And sometimes the paths overlink, intertwine, help each other. Sometimes they stand in the way of each other. But hopefully more often than not, they help a person who's struggling, who's bouncing back and forth between how the family's managing with them and what's available in the facilities down the way and what's not, and maybe a little bit of criminal justice comes in, rolls in on that too, and you don't know what's going to pave, what's going to start the path for somebody to actually move into recovery, which is probably why all of these things are important all at once.
No, I mean, I think, the research I've done is very humbling. Like I've spent my entire adult life looking, observing, trying to learn, opening my heart and eyes, trying to see. And, I mean, I do think that's why I like the cereal analogy so much. Like there isn't a single path. People need different things in different orders. And so, let's just have a system that can accommodate that would help us a lot. Even the stuff around dosing, like there's some rules around methadone dosing that certainly makes sense in the first week. But after that, I mean, you should be trying to get people enough methadone so that they don't have to use fentanyl, which might kill them. Right. I mean, that's part of the argument for safe supplies, so, safe supply interventions, right? What makes our illicit drug market doubly dangerous is nobody knows what's in any of it. Literally. I mean, even with the drug testing, you can get an idea about, the kinds of things that are in it, but you don't know the ratios often. And, you don't know the potency, you don't know the dangers. So.
Well, here's a comment from Marcy Wintermute, who's been a social worker for over 20 years. It's so important to be proud of all the big and the little wins with our people we work with. What seems like not much of a difference, impact, or change can be more significant than we really know. So grateful for this conversation today. So I guess that's a nice way to just sort of remember that the things that we want to see huge impact from may have small impacts that we may never see.
Yeah, I think that's a great message. I mean, the other thing I want to uplift in the time we have left, and I'll try and do this quickly, is, folks working in these areas, are harmed by the system that we've put in place as well, right? Because they haven't been given the flexibility or the resources they need. And so, a lot of that turns into burnout. It can turn into sometimes cruelty, right? Because you just can't take it. Like, why isn't this working? And so, I do think having greater generosity and flexibility is actually an occupational safety intervention for people who work in this field because there is a lot of futility because you're not able to give people the things that they need um, in the ways that they might want them, and so that leads to what feels like failure, but is really just is really system inefficiency. So we have been doing research with my group led by Sid Ganesh, who's in my postdoc now, trying to look at the moral injuries that are experienced by physicians treating people with infective endocarditis, or social workers, trying to get people housed, and you have this Byzantine, siloed. Well, if you're a veteran, we can house you there. If you're a woman, maybe here. Like all of these crazy rules that get in the way of helping the person in front of you, and then frontline workers in harm reduction, right? Who are living in solidarity with people who are, facing just horrendous assaults every day.
Yeah. Well, maybe you'll have some thoughts to help out this person in Iowa, where they're showing that saying that one of their skilled nursing that there's a general barrier in skilled nursing and nursing homes for accepting patients that are on medication for overdose use disorder. Is this a personal preference for them, they're asking, or any thoughts about how to change the way to perceive medical treatment for overdose use disorder so that it's not a barrier for those who are on medication in their recovery journey?
Yeah, I mean, I mean, would you not house someone for taking aspirin for having a headache? Like, it just doesn't make any sense to me. Like, there are all these. I mean, there's two things that don't make sense to me. I mean, there are many things, but in this regard, like, I mean, the first thing is if you have a patient who's stabilized on buprenorphine or methadone or Vivitrol, why would you disrupt that? Like, just like, I don't understand. Like, I literally don't understand that first. Like, why would you stop that? Like, it's a gold standard effective medication that's working for the patient in front of you. Why would you not do that? So that's the first thing. That doesn't make any sense. I mean, I think the second thing is if someone has an opiate use disorder, we do have these biomedical interventions that really work well. We should be using them every chance we get. Like every chance we get. Someone comes to the emergency room. Are you interested? Can we get you on methadone or buprenorphine? Because every time they're using that safe pharmaceutically produced medication, they're not using an illicitly manufactured thing that has God know what's in it. Right. So in a weird way, I feel like we need to get out of our way and let people get access to the things that they actually need. And certainly in the skilled nursing situation, I mean, you'd be insane to take them off of it because the truth is there's a decent chance they will return to illicit drug use. And now you have a really hard problem on your hand when you're trying to take care of someone. So I think we just need to, like, we have effective tools, let's use them. And let's use them as much as we can. I mean, I'd love to live in a world where it was cheaper and easier to get methadone than fentanyl. That would be a great world to be in.
Well, so many thoughts and comments from the audience in the Q&A, and I just don't even have a chance to get to them all, but we've been reading them, and we certainly will be keeping them in mind as areas that we might want to go into in our next couple of episodes of this series. But I want to ask you, just to finish up, if there's one message that you want every participant to leave with today, what would it be? And what gives you hope right now in this work?
I would listen to people who use drugs, and that's what gives me hope. Like, when we listen and we are thoughtful and we do the things they suggest, we usually end up with a much better outcome than if we don't.
That's a very, very, very powerful ending note. And I can see our audience is very appreciative of your comments, and they said so frequently in the Q&A. So Michael, I really want to thank you for taking this time with us. It matters a lot to us that people with your kind of experience are interested in sharing with us, and to the audience, all of you, everybody participating today, and the people still sitting there thinking, well, maybe I want to make a comment, maybe I don't. Come back to the next one and say what you got to say, tell your story, and help us to lift up what your experience is, because it's very important, and we can't do this work without you. It's the people that we are lucky enough to know and bring to the screen, and it's all of you who come and participate and give us your hearts and your minds and your thoughts. That's what makes this really, really, really useful. So thank you again, Ricky. Thank you to our audience. And just on the last slide, let anybody who's interested, let us know how we can support your overdose prevention efforts. So just contact us at nopn.org/contact, and we're more than happy to try to link you to whatever resources that we can. So just as a final thank you and goodbye, and see you next time.